Afternoon, everyone. My name is Nathan Seepaulsing, and I'm a third-year internal medicine resident at the University of South Florida. I'm going to be presenting a topic on sonographic screening for abdominal aortic aneurysms. Here's a brief outline for our talk today. We'll be going through an overview of the condition, giving some definitions. We will talk about how best to prepare yourself and your patient to have a successful screening exam. We'll go through the screening protocol, as well as discuss some of the management of abdominal aortic aneurysms based on your imaging findings. And we'll cap it off by discussing the feasibility of office-based screening. When we use the term abdominal aortic aneurysm, or AAA for short, what we're describing is a focal dilatation of the abdominal aorta. Typically, the dilatation is greater than 3 centimeters in maximum diameter, or can be greater or equal to 50% of a normal proximal segment. Abdominal aortic aneurysms are far more common in males as compared to females. In fact, some studies suggest up to 4 times as prevalent in men. The prevalence of the condition also increases with age. Perhaps the strongest risk factor for AAAs is smoking, although other risk factors include being Caucasian, having a family history, having a thoracic aortic aneurysm, or an aneurysm of another large vessel, as well as uncontrolled hypertension or hypolipidemia. Abdominal aortic aneurysms are often clinically silent unless they leak or rupture, so they are most often identified incidentally or through dedicated screening. A classic vignette for a AAA is a patient with a pulsatile abdominal mass, although this finding may only be present with a very large aneurysm, and so it isn't always a reliable indicator for the condition. Rupture is probably the most feared complication of abdominal aortic aneurysms due to the extremely high mortality rate. In fact, 60 to 80% of patients who experience a rupture will die before they ever reach the hospital or an OR. It's a grade B recommendation per USPSTF guidelines to offer one-time AAA screening for men aged 65 to 75 if they've ever smoked. You can use your clinical judgment and offer screening to men in the same age group who may not have a smoking history, but who have relevant personal history, family history, or other risk factors. That's a grade C recommendation. And there's actually insufficient evidence to make a recommendation for women in this age group, even if they've smoked or have a family history or other risk factors of abdominal aortic aneurysms. When we discuss the strengths and limitations of sonographic screening for AAAs, we find that using point-of-care ultrasound can be fast, it's inexpensive, we don't expose the patient to radiation nor IV contrast, and studies have shown high sensitivity and specificity for the screening exam. Some of the limitations we encounter: some technical difficulties, sometimes due to body habitus or overlying bowel gas. And this exam is really ideal for screening. It's a poor choice for procedural planning or if you encounter a complex lesion in the aorta. Moving on, we'll talk about how to prepare for a successful screening exam. When we think about probe selection for this exam, curvilinear, if you have access to it, is going to be your best bet. It has a good footprint for the exam, and we typically use the curvilinear probe for intra-abdominal structures. However, you can use the phased array probe. For instance, if you're using a handheld butterfly to conduct the exam, you'll be using a phased array type probe, and that works just as well. You're going to want to make sure your patient is supine so that we get access to the structures we need to view. And you should plan to examine the entire length of the abdominal aorta, starting from just below the xiphoid process to the bifurcation of the aorta into the iliac arteries. There are a handful of views that you'll want to obtain to demonstrate in the EMR that you've adequately examined the abdominal aorta. So 5 views in total, tracking the abdominal aorta inferiorly. You're going to take transverse views at the proximal, mid, and distal aortic segments, and you'll want to include the distal aorta bifurcating into iliac arteries, and you take sagittal views along the course of the aorta in each of these sections as well. So let's review some images from a screening exam I conducted on a patient using a handheld butterfly probe. I just want to note I gave myself about 3.5 minutes, give or take, to conduct the entire exam. It's a little bit of a specific amount of time, but I'll explain why I chose that a little bit later. So we're looking at the proximal aorta just below the xiphoid process in transverse view. There are some structures we can identify here. So proximal to the probe, we see the left lobe of the liver. Very distal from the probe, we see a spine sign. And just above it, there's a pulsatile vessel, which is our abdominal aorta, and lateral to it, the IVC. So here we have the mid-aorta in transverse view. We can see a pulsatile aorta in the middle of the image. A little tip, when you're in this segment, you may need to apply pressure with the probe to displace bowel gas in order to optimize your image. So here we have the distal aorta in transverse view, general medical orientation. On the left-hand side, we have abdominal aorta of normal caliber. And on the right-hand side, we see as it starts to bifurcate into the left and right iliac arteries. For most patients, the bifurcation typically occurs around the level of the umbilicus. And so you have a couple options to obtain this image. The first is to kind of fill the umbilicus with ultrasound jelly and kind of get rid of any air interface with the probe. Obviously, that sounds like it can be a little uncomfortable for patients. And so another way you can obtain this image is to go just superior to the umbilicus and then fan down in order to get the bifurcation, or go just inferior and fan up. Here is our sagittal view of the abdominal aorta in general medical orientation as we move down, caudally along its course, adjusting the probe to keep it in view. So we've successfully screened our patient for an abdominal aortic aneurysm. We've taken our measurements, and now we're going to look and see what follow-up we need for our patient. So the American College of Radiology gives really nice guidelines on how we should handle our findings from a sonographic AAA screening. Typically, if the maximal diameter is 2.4 centimeters or less, no follow-up imaging is recommended. However, once we reach this threshold of 2.5 centimeters, imaging intervals increase from 5 years to 3 years, 2 years, 1 year. Once we reach 4.5 centimeters, the imaging intervals really get close together, Q6 months or even Q3 months. However, if we're at that threshold, we should refer our patient to surgery or vascular to consider repair. Oftentimes as physicians, we identify patients who qualify for AAA screening. We provide them with the imaging referral. They go have the study done, and then we review the results at their next visit. However, there is data to show that an office-based screening protocol is technically feasible, and I will argue financially feasible as well. A pilot study from a rural family medicine practice in Canada examined the question of whether an office-based ultrasound screening protocol for abdominal aortic aneurysms was technically feasible. In this study, a resident in the clinic was trained to complete a POCUS screening exam measuring the maximal abdominal aortic diameter using POCUS. About 45 patients were screened, most of them men, but all of them meeting guideline recommendations for screening. There was no statistically significant difference between the office-based protocol and the criterion standard. In fact, the mean absolute difference between the scans was only about 0.2 centimeters. The office-based screening had 100% sensitivity and specificity, and interestingly, the mean time to screen was only about 3.5 minutes, which is why I chose that time frame to conduct my own screening exam. 3.5 minutes is not too long, and it makes conducting an office-based screening feasible when we consider how busy an outpatient family medicine or internal medicine practice is. So we just saw some data which suggests that the technical component of an office-based AAA screening protocol is feasible. However, I wanted to do some more investigation into whether this made financial sense for an office. So here we have a chart which is reflecting 2024 Medicare reimbursement rates for sonographic AAA screening in Hillsborough County. And I'll walk us through the chart. So we have HCPCS code 76706 and the associated descriptor, ultrasound of the abdominal aorta, screening for AAA. And we can see that if this exam was conducted in an office, Medicare would reimburse right around $100. There's a couple modifiers here, and I'll explain those quickly. So the 26 modifier is the professional component of the exam. This is indicating that a physician or another qualified healthcare professional is adequately interpreting the results of the screening exam. Medicare reimburses right around $25 for this component. And then we have the TC modifier, which is the technical component. Medicare reimburses right around $75 for this modifier. And basically that just indicates the time that it takes to physically do the screening ultrasound. And you'll notice that if you add the 26 and TC modifiers together, they equal the reimbursement rate for the exam, which is right around $100. Not too bad for 3.5 minutes. Thanks to everyone for watching the presentation, and I hope that you all learned a little bit about using ultrasound to screen our patients for abdominal aortic aneurysms.